Madam, you can start your talk. Please unmute yourself.
I'm sharing screen now. Can I share?
Yes, yes.
Assalamu alaikum, my dear colleagues, students, ladies and gentlemen. Welcome you all to our today's lecture class. Our teacher today is Dr. Jamil Abdulaziz Al-Atta. He is facing some computer problem. One of his computer crashed and now he is working with the second computer. I wish he will join us soon. By that time, I will give you his introduction so that you can save some time. So his pre-medical education was from King Faisal High School in Jeddah, Saudi Arabia. And he completed his school education in 1982, medical education in 1988 from King Abdulaziz University, Faculty of Medicine. Then he did his internship up to 1989. From 99 to 91, he has Canadian evaluation examination, which he passed. And then he did residency 2 times, once in Saudi Arabia from King Abdulaziz University, and then from the Montreal Children's Hospital under the McGill University. And you know the McGill University, which is a very famous university in Montreal. And then he did his pediatric cardiology fellowship from the same university, from same hospital, then echocardiography fellowship from the same hospital, Montreal Children's Hospitals under McGill University, and interventional pediatric cardiology fellowship in 1997 from the same university. So he has a lot of certificates. In 1989, he has certificates of internship from Saudi Arabia, King Abdulaziz University, then American Board of Pediatrics in 1994, McGill University in 1995. In 1996, he has certificates in pediatric cardiology, 1997 in fetal echocardiography, and then in 1998 in cardiac catheterization. So his present appointment, he is the chairman of the pediatric cardiology unit at King Abdulaziz University Hospital from 2014 till today. He is the chairman of community service unit at College of Medicine, co-chairman of cardiac catheterization laboratory, head of the pediatric cardiology section of the King Faisal Specialist Hospital, chairman of the ethical committee, and consultant of pediatrics and pediatric cardiology in King Abdulaziz University Hospital from 1998 till today, and consultant pediatric cardiologist in King Faisal Hospital and Research Center from 2000 till today. So he is working simultaneously in multiple positions in multiple hospitals. His expertise is he is the pediatric cardiac interventionist. He can do all the procedures, except he is not doing perimembranous BSD closure. Why he wrote this, I don't know, because I did few of the perimembranous BSD closure with him in our hospital during the charity mission, and he returned back and he was telling me that he named the procedure in his hospital in my name. He was telling that I learned this from you, so I gave your name for this method of closure of the BSD. Then fetal echocardiography intervention in coronary artery fistula, occlusion of AV malformation, pediatric TEE, and even he is also involved with airway stenting in children. Airway stenting means stenting in the bronchus, trachea, and other small airways. He has a lot of special honors and awards, like English for medical science students, then hospital grand round certificate. In his college life or school life, he was awarded with the best biology student. And then he has lot of excellency award in his internship type, basic life support certificate time, and also he received Prince Bandar bin Sultan certificate of regulation, recognition, and also ambulatory pediatric coincide update for the generalist application. So he is involved with many activities, and he received the recognition for all those activities in several times. So with this, actually, I am waiting for our today's guest speaker, Dr. Jamil Alata. I'm just checking whether he is fine.
Assalamu alaikum wa rahmatullah.
Assalamu alaikum. Welcome. Welcome, Dr. Jamil Alata. So I have just finished your introduction. Now you can start with your speech.
Sure, I will start joining. Thank you for inviting me to this great webinar. I'm very pleased to be with you all. I enjoy really being with the cardiologists, the fellows. I kind of try to spend my life in teaching and spreading experience. As you have noted that I'm mostly an interventional guy, and today I'm going to talk about medical disease. So bear with me if you find it a bit boring, but inshallah we'll exchange information and make the best out of this session. Doctora.
You can share your screen, Dr. Zamil. Share screen.
Yeah. Doctora, Professor Noor Nahar, what time do I have?
You have 1 hour time.
1 hour time. Okay. Inshallah. So I'll just share my screen.
Your slides are visible now.
Okay. So the topic today is quite a big topic, which is acquired heart diseases in children. I'm pleased to be with you all, and I hope I can make some dent in your education and information. Topics to be covered in the best precise way I can do is rheumatic heart disease or rheumatic fever, Kawasaki disease, and a touch on myocarditis. I have no disclosures to bring up. So we all know that rheumatic heart disease or rheumatic fever is an immune response primed by group A strep infection or gas infections. And 46% of episodes are with no preceding ARF, and it usually goes or comes after the first 1 to 3 weeks post gas infection. And why do we say here 46% are of no preceding ARF? Because we diagnose each episode as a new one or a recurrence. Incidence varies quite a lot. And as you can see, it's anything between 0.2 to 2 cases in Western Europe. And it can go up to 50 cases per 100,000 population in endemic parts of the world, in our world precisely. Susceptibility to group A strep infection, immune response, housing, and overcrowding are considerable risk factors. We really don't know how the immune system really responds, but we know that these are risk factors for developing and recurrence of RHF or ARF. Acute rheumatic fever is a clinical diagnosis established by applying the modified Jones criteria. So you all know we have the major criteria, or they are the polyarthritis in about 70% of the cases, carditis 80%, erythema marginatum and subcutaneous nodules represent about 5%, chorea in about 28%, and usually chorea presents late, about 2 to 6 months after the real episode that happened, or it could be the first episode that happens ever. The polyarthritis in rheumatic fever is a large joint polyarthritis. So whenever you find small joint polyarthritis, clinical exam is so important, or any joint deformity, we know that we are dealing with something else. And we know that rheumatic fever actually can intermix with other arthritis causing even the simple post-strep arthritis. And sometimes in these cases, we really don't know, is it rheumatic or not? So we grab the stick from the middle and we treat those, prophylax those patients for about 5 years until another episode comes and confirms, or it would be the one and only response. I can tell you, I have never seen subcutaneous nodules in the past 25 years I'm practicing. I don't know how much you guys have seen it. For sure, erythema marginatum seen, chorea we see, and more in girls. Minor factors, fever, arthralgia, so pain. And here we see a lot of pediatricians really diagnosing rheumatic fever or acute rheumatic fever based on an arthralgia and a high ASO titer. I get so many referrals of such patients labeled as rheumatic when they are not. We really look for arthritis by the full-blown picture, inability to use the limb or the joint, and the erythema, the redness, the hotness, the swelling, and so on, not just the arthralgia. Previous ARF episode and CRP, ESR, which are elevated, leukocytosis is one, and the first degree AV block, ECG, prolonged PR interval are all minor criteria. So we need 2 major and 1, and or 1 major and 2, but we definitely cannot take 1 major and 1 minor from the same origin. So if you have carditis, you cannot use PR interval being prolonged as part of your minor evidence. Evidence of gas infection is a must prior to diagnosis. So ASO titer, positive culture, positive rapid antigen test, nuclear enzymes testing, scarlet fever are a prerequisite. They are not part of that criteria. And I have seen diagnosis of rheumatic fever based on just an elevated ASO titer, like something like 600 or 800. In areas heavily endemic for strep infections, you may have a lot of people showing immune response as a high ASO titer, but they are not rheumatic fever. So be very careful. This is another pitfall that we see in our practice, being sent patients with high ASO titer who already are on long-acting penicillins for no good reason. Yet, the high index of suspicion of rheumatic fever is so important for us in our world because we really want to prevent the burden of cardiac or chronic cardiac involvement and valvular disease. Clinical and investigations, arthritis is what you really have to take a lot of history about and confirm clinically. As I said, it is not associated with small joint. It is not associated with deformities. It's a true arthritis and so on. Carditis can be quite silent. We may not know about it until we do the echo and find echo evidence of carditis. And the echo evidence of carditis can range from just a mild pericardial effusion, mild MR, mild AI, to significant carditis with function abnormalities and severe valvular involvement. And remember here, it is, or rheumatic fever is one of the causes of pancarditis. So we have pericarditis, myocarditis, and endocarditis. Subcutaneous nodules are seen on the bone shafts and the tendons. Chorea is the typical purposeless movement of mainly large joints. Usually it's very jerky, and sometimes it's associated with dysphonia and emotional difference, although emotional liability should not be part of chorea, but it can be. Heart failure can be a presenting symptom, whether it's because of the carditis itself or it's related to the AV valve, like the mitral regurg or severe aortic regurg. Usually it's the mitral regurg combined with a severe myocarditis episode. Treatment and prophylaxis, what's the aim and for how long? We treat these patients with rheumatic heart disease or rheumatic fever because we want to prevent any damage to the heart. Arthritis is quite self-resolving, and when you treat it, usually it leaves no effect. Chorea usually disappears and rarely recurs, and rarely leaves very minor symptoms or signs. The heart is really the problem. The heart is why we are really aiming at treatment and prophylaxis, and especially prophylaxis much more than treatment. And here again, there's a mix in the student fellows and some of the pediatrics practitioners that prophylaxis means what SBE prophylaxis means. No, they are totally different. Here it's the long-term prophylaxis or with penicillins, whether long-acting or oral, for almost life. And it's not the episodic prophylaxis we provide for SBE when we're doing a procedure. Even rheumatic heart disease patients, when they do have a procedure, even when they are on long-acting penicillins, they should take the SBE prophylaxis to elevate the serum blood level of the antibiotic to prevent endocarditis at that stage. I think before going into aspirin, steroid, and others, for how long do we prophylax these patients? I guess you can choose so many criteria. Today, there are so many talk about how long. In my practice, what I would do if I have a patient with rheumatic fever and with or without heart disease in our area in Saudi Arabia, I usually treat these patients with prophylaxis till they are 18 years of age, regardless of what valve disease they have. We found in Saudi Arabia, the incidence of recurrence after age 15 is extremely low. And you know, the compliance with prophylaxis is quite difficult to get patients to prophylax. But if you want to go by the international criteria, then we prophylax for life or almost up to 40 years of age when they have ongoing valvular disease, or up to 18 when they do not have any valvular disease. Aspirin is a mainstay of therapy in patients who do not have congestive heart failure when they have rheumatic carditis. How long do we treat them with aspirin, and what's the dose? The dose is moderate to high dose aspirin, anything between 50 to 100. I usually go 75 to 100 per kilo per day divided Q6 with antacids. Aspirin, for how long? Would you go by inflammatory, reactive inflammatory markers like an ESR or CRP and then reduce your aspirin? I guess that's an area of major debate, because these markers can go down easily within the first 2 weeks, 3 weeks, and can stay high for a very long time. I usually treat these patients for at least 4 to 6 weeks of aspirin, even if their ESR or CRP goes down early in the treatment, like let's say 3 weeks, and they become free of symptoms, and the echo is quite good, no more effusion, no more poor function, the MR or the TR, we don't wait for it to improve because it would improve later on. So again, this is a tricky area. We have seen in patients who are African origin, who are in Saudi Arabia, that actually their myocarditis from rheumatic fever can remain for a long time, up to 3 to 4 months. And sometimes that's the time you need to treat patients for as long as that. And this is quite important because some of them may need to go to cardiac surgery, and we cannot push them when they still have myocarditis ongoing. Steroids therapy for resistant cases, prolonged cases, or cases with congestive heart failure. The antibiotics, we give them the acute treatment just to clear their throat or their colonization for 10 days, and then they start the long-acting penicillin, which is usually given every 3 weeks, or erythromycin daily dose, or even amoxicillin daily dose on the ones we don't to give injectable long-acting penicillin for any other reasons. And for sure, anti-failure treatment, whether acute or long term. Commonly involved valves are the mitral and the aortic. The mitral is usually presenting with mitral regurgitation. In adolescents, especially girls, it can transform into mitral stenosis and need treatment. Treatment specific for rheumatic valvular disease with ACE inhibitors, diuretics if needed, and surgery for valvular heart disease when they become severe. Here I may say that in rheumatic heart disease, we usually see the trend that these patients, even if they have moving surgery. Are you hearing me?
Yeah, it's a little bit disturbing. Can you increase your volume a bit? Is it possible?
Yeah. Is it now okay?
Yeah, it's okay.
Okay. So surgery for rheumatic heart disease, valvular disease specifically, is usually needed later on in the disease if it is severe. And these patients usually tolerate quite a bit a mitral regurg and aortic regurg. And again, as a rule, in children, we try to push away surgery for their valve disease as much as we can until they are more towards the adolescent stage where they can be repaired or replaced. The issue of how to know when, I think the best parameter I would take is really following their EF or LV function. And as long that function and the systolic, not the diastolic, the systolic diameter are not terrible, meaning an EF for sure 60 and above, I would wait. If it is below 60, then you know that they are losing function. And it's even 58 may be normal for a normal person, but it's not normal for somebody with severe regurg because obviously they are losing myocardial elasticity and turning into a bad way. For systolic diameter, it's important. The diastolic can go up to 4.5, 5 centimeter, that's fine. But when systole becomes over 4 centimeter, then you really know that this heart is getting dilated. And eventually, mitral stenosis disease is a good interventional area where balloon dilatation is quite effective in adolescent girls and in ladies for their mitral valve, as long as they meet the criteria. I think by this I tried to cover acute rheumatic fever, rheumatic heart disease. We can give maybe 5 minutes of quick discussion if there are questions, and then I can go to the next topic, which is Kawasaki disease.
I just want to ask you about the incidence of rheumatic fever. In our country, we are seeing a dramatic actually reduction in the incidence of rheumatic fever because of the improvement of the socioeconomic condition. Before, we have many slum dwellers and congested household in one room, lot of people were living together. Now there is some improvement in the among the lower socioeconomic classes, and nowadays we are seeing that our like PTMC hardwares in the cath lab, they are sitting idle. We are not seeing people are doing PTMC like they were doing in 2000, like in the year 2000 to up to 2010. And after a long time, I did one of the PTMC in March of this year. And that was the first PTMC here in last 10 years. And all the nurses, they have forgotten how to assist and how to prepare the trolley. So I have to actually teach them again how to prepare the trolley, how to do everything. So what is in your country, status in your country? I think it's much better than us.
Well, I think we still see new cases for sure, much less than maybe 20 years ago. I think we do still see in adult intervention structural disease, or let's say maybe 4 or 5 cases a year of mitral stenosis, needing balloon for sure. This is just in the western area and maybe more in other areas. Remember, in Saudi Arabia, we are a very multicultural, open country. We get people from all over Saudi Arabia for Umrah, Hajj, visitors, and they come actually with their children and so on, and we see their disease. So our incidence in Saudi Arabia and prevalence is not pure Saudi Arabia population. And I think from what I guess from what you said, you probably are seeing less than us now. Uh, but for sure, we are still seeing, I would say, a recognizable number, much less than before, but we are still seeing it.
Yeah. Thank you so much. In South Asia Forum, we have a South Asia Forum in APPCS. You know, the Asia Pacific Society of Pediatric Cardiology and Pediatric Cardiac Surgery, APPCS. And there is a South Asia Forum there for the rheumatic fever. And I'm seeing that actually Bangladesh is performing better even than that of the India. And our reduction rate is much better than them. And with us in South Asia Forum, Australian pupils are with us also. But because of the aborigines and other people, we have like one kind of people in a country. As you were telling, you have some mixed population like African populations, and from the Hajj and Umrah, you are getting a lot of other country people are going there, and that is maybe a reason for more incidents. But in South Asia Forum, we are seeing that in every country, there is trend of reduction than that of the before. So I think if there is no more question, we can proceed to the second topic.
Madam, can I?
You want to say something, Dr. Salam?
Yeah, nice to see. His Excellency Professor Jamil Al-Ata. Me, Professor Abdul Salam, I think you could remember me.
Yes, I remember. I can see your face. That's more reminding for me.
Sir, excellent delivery regarding the rheumatic heart disease. But one important thing that is, as Madam Noor Fatima was telling, as also you are telling, the incidence and prevalence of rheumatic fever is decreasing. But in my practice, while I was working in a government hospital, tertiary care cardiovascular center, I found there are some seasonal variation of rheumatic fever. Uh, seasonal variation. Sometimes the incidence become higher than other times. And still we are finding some cases in our center because our center is giving the service almost the poor people of this country. But my question to ask to you, that is the how we can diagnose the subclinical rheumatic fever by echocardiography. I think you are well aware that WHO and has accredited some echocardiographic classification for early identification of valvular pathology related to rheumatic fever. So I think for the students, it is better to know this criteria because the disease is regressing. So before developing any valvular or endocardial pathology, we have to know to identify those features in case of any doubt or suspicion of rheumatic fever. Thank you very much.
Thank you, Dr. Salam. I think we do see, you see, rheumatic heart disease is part of the most diseases with myocarditis. And we know that myocarditis tends to be a lot subclinical, a lot missed, and we don't really diagnose these diseases. Probably we are not diagnosing all these patients, and some are going, you know, if they get a knee pain and maybe a swelling on the other knee, and in 5 days everything disappears, and they had an episode of carditis with it, which is just mild, probably many of those are walking there, and we are not detecting them. So a high index of suspicion is a very important clue. I'll take your first point about the seasonal variation. I have not read it anywhere that there is significant seasonal variation, but for sure when it relates to group A strep infection, you can see that it can have a seasonal variation, whether in the windy times, whether in the cold times. What makes people crowd in a room is really sometimes to seek warmth or warmth, and that's why they may get this disease. So there could be. Regarding the echo criteria,
You are not audible, Dr. Jamila Lata.
I think it's good.
Yeah, now it's
My
coming.
internet is not so stable. Yeah. See, I was saying that if we're looking for echo criteria to diagnose rheumatic heart disease, then it's already happened, but it's good because if you can detect a patient early, you can start the prophylaxis, which is the most important part of treatment. But how can we do? Are we suggesting here to do echo screening programs for certain ages, let's say 5 to 15, to do that, or utilize echo much more than we are doing? I'm not sure really how we can apply this criteria unless there is a suspicion to start with. Suspicion from repeated sore throat, suspicion from arthralgia complaints, rashes, chorea sometimes can be the first thing to tell us. So the criteria, for sure, changes in the mitral valve, buckling, comma shaped, finding the MR, thickening of the valves, and so on. So many things. But again, I wish we can come up with a program that actually can screen. Are you, Dr. Salam and Dr. Noor Nahar, aware of any ongoing screening programs? I know India maybe had something like this long time ago. Are you aware of any?
Actually, for Dr. Salam was asking for subclinical carditis, not overt carditis, which is visible in the echocardiography or by Marmar or other things.
Sure.
Subclinical echocardiography from American College of Cardiology, I usually use one criteria of them in my echo lab is that presence of systole or presence of MR jet throughout the systole. If MR jet is present throughout the systole, even if there is no other criteria present, then it is one of the criteria for subclinical carditis. So this criteria I am using for a long time. And again, there is a thickened mitral valve, leaflets, tip of the mitral valve, and other things are there. But that one I found very useful in my clinical practice, that presence of MR jet. If MR jet is present only in early part of the systole, that is not significant. But if it is present throughout the whole systole, then it proves that it is a subclinical carditis. So that is one. And another question is for you, Dr. Jamil, in the chat box. Colonel Hannan asked the question, what is the incidence of surgery from the rheumatic heart disease in your country?
Okay, I agree with the notion you mentioned, Dr. Nur Nahar, Professor Nur Nahar, about the MR, and actually this is what we are using, but we did the echo looking for it. It means we had the suspicion that this patient could be running a carditis and we're not sure. So that's why we did the echo, and this is where it is very useful. Incidence of surgery, I think let me put it in a different way. The most common cause of valvular surgery in adolescents and
Sound is not audible, Dr. Jamil.
in Saudi Arabia remains. Is it audible now?
Yes, now it is audible.
Yes, sir, it's audible.
Okay, so I was saying in Saudi Arabia, the most common cause of valvular surgery remains in adolescents and children remains rheumatic heart disease. So it is still the highest cause of and Coronary or kind of presume the incidence. We do have congenital MR, congenital mitral stenosis, AV canal valvular diseases, surgery, rheumatic heart disease in children, older children, and adolescent heart surgery.
Yes. Assalamu alaikum, Dr. Jamil Ata. That's Dr. Hannan. It's a very nice lecture by you. Actually, I was asking in the pediatric age group regarding the rheumatic valvular heart disease. What are the incidents of
Yes.
in these age groups required to need for surgical intervention? Because we got the valvular rheumatic heart disease, we got for repair or replacement almost in the adult age, and with the prophylaxis, we wait up to the adult age. But in the pediatric age group, how much it required and what are the indications? Thank you.
Are you asking about endocarditis?
He is
No.
asking about incidence of surgery among pediatric age group from the
In
rheumatic
the
heart disease.
rheumatic valvular heart disease.
Trying, I cannot give you a number, but I can tell you the most common cause for valvular heart surgery in Saudi Arabia for children who are 9 years to 15 is rheumatic heart disease. It's the most common cause.
Thank you, Dr. Jamil. I think Dr. Hannan, Colonel Hannan, he got his answer. Now I think we can proceed to the next topic.
Okay, so next topic is rheumatic heart, is Kawasaki disease. And bear with me, a busy slide, but I tend to put points and talk about them instead of really writing everything. So Kawasaki disease is for sure a relatively rare clinical diagnosis, anything between 20 per 100,000 in rare areas and up to 300 per 100,000 population. And where we see that 100,000 population, 300 per 100 is actually in Eastern Asia and the Pacific Islands like Hawaii and so on. Usually affects children who are less than 5 years of age, with a peak incidence in around 9 months of age. Today, we are seeing much more atypical Kawasaki. I find it quite a challenge in our practice today as cardiologists, because we are getting much more of these diseases. And just to tell you that Kawasaki today is no more the Kawasaki we knew about 30 or 35. I think the first case of Kawasaki I have seen was probably 1989, and it was diagnosed before that. So Kawasaki disease is no more the same. We have Kawasaki, we have the multi-system inflammatory disease, we have Kawasaki-like features with COVID, and so on. Kawasaki is really now becoming a very different spectrum that we have to be very careful in diagnosis. We used to say, if Professor Noor Nahar Abdul Salam remember, we used to say if a child has fever, continuous high fever for more than 5 days, they have the unilateral lymphadenopathy, they have the erythema, they have the cracking of the lips and the conjunctivitis. These 5 criterions are typical for the diagnosis. I may ask you now, how many of you are seeing these typical Kawasaki features today? I am sure I would say not many of us.
Dr. Jamil, we are actually getting more Kawasaki disease nowadays, especially with the COVID scenario.
Yes.
And before that also, suddenly for last 8 to 10 years, we are getting too many Kawasaki diseases. I have published an article with many cases. And then after in post-COVID, like after suffering a COVID, 2 weeks or 4 weeks after the COVID positivity, that many of the children are coming now with the Kawasaki-like feature, as you have mentioned, which is PIMS TS.
Professor Noor Nahar,
Yeah, we are getting.
were typical Kawasaki.
Yeah. These are not all complete Kawasaki,
Yes.
but incomplete Kawasaki-like features.
That's true. So this
But,
is the point to bring up, that we are today seeing a lot of those incomplete Kawasaki patients or atypical Kawasaki patients. And that's why today we do look for other signs like anemia unexplained for age, like the low albumin, leukocytosis, or leukopenia. And you know that leukopenia is a poor sign of really developing coronary heart disease if they have it. So today, you really have to have a wide vision and clinical sense to diagnose Kawasaki. Multi-system inflammatory diseases, Kawasaki post-COVID, and the atypical Kawasaki are probably now more than the usual, very typical Kawasaki we used to face a long time ago. Cardiac and vascular findings are quite important in establishing the diagnosis. So not only the clinical criteria, not only knowing the atypical ones and the circumstance and the season, but also cardiac and vascular findings. So when we do an echo and found coronary involvement, or find pericardial effusions, or poor function, or valvular disease, not only just coronary, then you know that whatever inflammatory process you have has a cardiac part to it. And then the differential goes on from there. And knowing this, especially when the coronaries are involved, then you get your diagnosis. But we know Kawasaki disease can come with normal coronaries. So it's really a high suspicion index on a clinical situation. Other vascular findings, aneurysms of moderately large vessels can happen with an iliac or renal and others. So we may need to use other modalities in the diagnosis. I already passed by the anemia, the low albumin, the leukocytosis. Pathogenesis is very poorly understood. And if you want a subject where you can mention any pathogenic cause as possible, Kawasaki is that disease. So genetics, it has been seen as a trend in twins. Siblings have
You are not audible again.
higher incidence. If one sibling has it, others have higher incidence. Familial aggregation is also a seen pattern. Single nucleotide polymorphisms are also associated with Kawasaki. Vaccine exposure can be blamed sometimes. Viral, like adeno and EB virus, up to 10% of cases with Kawasaki. Adenovirus was isolated in certain studies. Bacterial toxins, fungi, even wind time and wind action can bring and carry toxins. And people have seen that in windy times, the incidence of Kawasaki gets higher. Even carpet cleaners have been involved. So it's a multi-inflammatory system disease that has predilection to vessels, especially the coronaries, and that is quite really poorly understood. Immune factors that can be also investigated and tell us a bit more about the disease. Things like pathogen associated molecular patterns or damage associated molecular patterns, pumps or dumps, can be an evidence if we really have to go to and diagnose Kawasaki more. Cytokines elevated. Plasma B cells have been reported in the early phase, suggesting their role in the damage happening. Regulatory T cells go high up in numbers after IVIG treatment, and they suggest recovery. And whenever we see memory T cells, then really the risk of recurrence is high, and the risk of coronary heart disease is also high. So you can see how complex this disease is. And for the last 2 points, which is the immune factors and the pathogenesis, when we have such difficult cases of Kawasaki, obviously, whenever we suspect Kawasaki, we treat Kawasaki. We don't wait, because we know that in Kawasaki disease, you have the window of the first acute phase, then the subclinical, then the recovery phase. And it's really in the subclinical, the second phase, and the the recovery phase, where it is the highest incidence of coronary affection or involvement. And that's why we want to treat them well in the acute phase and start IV immunoglobulins. And sometimes, not to lose time in the patients which are quite atypical, we go for treatment, or we go for our colleagues in immunology, rheumatology, and infectious disease to get their input and do further studies to confirm the presence of such a diagnosis. So again, Kawasaki diagnosis is, as I spoke about the clinical part. What do we do for labs when we do look for Kawasaki? The mainstay we are looking for is really inflammation, so a high ESR, a high CRP, anemia, albumin below 30 grams per deciliter, and leukocytosis. We don't have much of an army to help us in the diagnosis unless we go to sophisticated investigations in difficult cases. Echo is an important diagnostic tool, And again, it is not only for coronaries, and again, coronaries can be normal. Pericardial effusion, pericardial thickening, AV valve involvement with regurgitation, like Dr. Noura said, important, not just a whiff, not just something in the start of systole, and so on. CT, both for coronaries and for other vascular parts of the body to detect whether in cases where we are in doubt, whether in cases we want, which are severe and we expect other vessels to be involved, or in follow-ups, especially when we already have established aneurysmal formation in the coronaries or in other vessels. One thing that many papers don't talk about, which is an ophthalmology exam. And I use that in the late presenters. Sometimes you get a patient who's already 15 days or 18 days into the illness. And the history goes that this patient had uh, uh, fever for like 9-10 days, then it got better. Then the patient comes to you with not much redness or cracking and already desquamating. And you really don't know, was it scarlet fever? Was it something else? Ophthalmology can help us, and anterior uveitis by slit lamp exam is a very pathognomonic sign. If you have that kind of a late presenter and you can prove that this patient has anterior uveitis, then this patient most likely had Kawasaki disease. Obviously, other investigations like platelet activating factor, and acetyl hydrolase assessment can help when positive and high, can help in saying that these patients are having Kawasaki disease. Treatment of Kawasaki is on suspicion. We do not wait for confirmation 100%. High index of suspicion. High suspicion means we go for treatment, and the main treatment is IVIG. We used to give it 5 doses over 5 days, long time ago, 400 milligram per kilo. Then we turned into 1 gram per kilo for 2 days, which 2, and obviously now we use it for 2 grams per kilo. But again, we can go back to the old style depending on the amount you're going to give. Sometimes the patient is in heart failure, sometimes you have to restrict fluid for any other reason. You don't have to really give it over 1 day or a certain number of hours. You can divide it over 2 days, and it can be still given over the 5 days old protocol if there is an incidence. Can we repeat IVIG? Yes. Within the first 3 days post first dose of IVIG, if patient has still low albumin, anemia, fever is not subsiding, there is a benefit of repeating a dose of IVIG. Moderate to high doses aspirin are started immediately with the IVIG, and when we say moderate, it's like 50, moderately high 75, and high is 100. I usually go directly to 75 to 100. I never use 50 unless there is an indication to prevent me. I'm worried about acetyl salicylic acid toxicity for any reason, liver involvement. Then we can go low on the dose. Low dose aspirin, when to start, that's another, I think, area of debate. I think I would never go to low dose aspirin until I see the CRP or ESR normalized. And this may take 2 weeks, this may take 4 weeks in the usual patient. If you go to the literature, a lot of practice is that when your fever subsides on high dose aspirin, even if it was after a week or 2, you immediately shift to the low dose aspirin, 5 milligram per kilo for an antiplatelet until we are sure in the next 4 weeks that the platelets are not going above 800,000. I usually don't take that criteria. I've been burned so many times with recurrence with coronary late involvement. And I've taken the way that I would treat them until they show no inflammatory signs. And this usually takes about 4 weeks with high dose. And then I assess the platelets and look at it. If it is high, I would put them on low dose. If it is not high, I would put them on nothing. And usually I have already treated this patient with high dose for like 4 weeks. Steroids have passed through a lot of debate over the past 2 decades, whether to use them or not. Early on, yes, then in the middle we said no more, no benefit. And we now know that they do have a role. We have patients who are refractory to IVG treatment, and these patients may benefit from adding steroids after the first 2 doses of IVIG and aspirin. Actually, there are studies now that show that when you see a patient who's not responding like he should, and you start steroids, not responding, I mean to IV and aspirin like they should, and you start steroids early in the time of the disease, then there is a good protective effect of that early start on coronary. So steroids do have a role to play in treatment of Kawasaki, especially the refractory or the non-properly responders in such patients. And then you will have to say whether you continue steroids and aspirin or just probably steroids. Probably you would just continue high dose steroids, and the dose is anything between 1 to 6 milligram per kilo per day of prednisolone or any equivalent steroid. Refractory Kawasaki can be faced, and actually we do see them not uncommonly. I'm not going to say it's common, but it is not uncommon to see refractory Kawasaki lingering on treatment. And these we really have to consider steroids, repeat IV, IG, or the newer treatment. Because again, remember, we are here after preventing coronary heart disease. That's the dreadful thing we don't want to happen. So tumor necrosis factor inhibitors, IL-1 inhibitors, calcineurin inhibitors like cyclosporin, or cyclophosphamide or methotrexate treatment can be involved. Again, when we reach these points on the slide, I think we as cardiologists are obliged to get help from rheumatology, immunology, and maybe pediatric hematology oncology, because it is not our area of expertise or follow-ups. And these patients, you really have to have support and better way of diagnosing. Coronary aneurysm treatment, obviously some cases will have none, and then you really don't have to worry. And once the disease acute phase is treated, ESR is normal, platelets are normal, then nothing to be treated. Aspirin is for those who have aneurysms around or dilatation around 3 to 4 millimeter, but definitely more than 3 and less than 4. We can keep them on aspirin until this is resolved. Patients who have aneurysms between 3 to 5 millimeter, we can add Plavix, clopidogrel, to their treatment. And by the way, I would want from Professor Noor Nahar and Dr. Abdul Salam to tell us what doses you usually use for Plavix, because I don't think this is agreed on. We can hear from you once I finish the slide. Or you go to aspirin, aspirin Plavix when they are 5 to 8, 3 to 5 with aspirin, and aspirin anticoagulation, and this anticoagulation either warfarin or low molecular weight heparin subcutaneously. And this is my preference because a lot of our Kawasaki patients are actually young. They are like a year old or a year and a half, 9 months old. And warfarin anticoagulation as follow-up is really not a good idea. So I usually keep them anticoagulated with enoxaparin, easy to teach the parents, easier to find, and easy to give. Obviously, advanced management I spoke about just in the slide before. Coronary interventions may be needed. One thing we always talk about Kawasaki disease as a cause of aneurysms, but we have to remember that it can cause coronary obstruction, whether because of the aneurysm and thrombosis, or because of fibrosis resulting from the initial inflammation. So don't be so happy seeing an aneurysm or a dilatation becoming totally back to normal. Follow up these patients, and that's why they need long-term follow-up, because they may develop actually stenosis and fibrosis and get some ischemic symptoms from their coronaries later on. I think this is my last slide on Kawasaki. And again, I welcome any comment or questions.
Thank you, Dr. Jamil. This is a nice presentation on Kawasaki disease. As I have mentioned earlier, that we are getting a large number of Kawasaki disease in my echocardiography clinic. Every day I got like 1 or 2 cases for evaluation of the coronary arteries for the Kawasaki disease. So when we say that Kawasaki coronary is dilated, when Z score is like more than 2. So more than 2, the Z score mean dilated Kawasaki, and then when it is like more than 8, then we say that this is aneurysm. So for only dilated coronaries, we use antiplatelet aspirin, like 5 milligram per kg in antiplatelet dose for the dilated coronaries. But if there is aneurysm, then in that case, we also add anticoagulant like warfarin. And sometimes if the patient is very sick, we even give IV heparin or enoxaparin like things. And I just want to ask you a question. Have you got any experience with angiogram of the coronary arteries or coronary angiography for the Kawasaki disease aneurysm or thrombus formation and then redilatation or stenting? Because you are working with advanced cases, have you got any experience with the coronary angiography followed by any intervention in the coronary for the Kawasaki disease? In addition, I just want to add that nowadays, our adult cardiologist colleague, they sometimes call me in their cath lab, seeing that beaded appearance in the course of the whole coronary artery in the adult patient. So they just want to know from me that whether these patients were suffering from Kawasaki disease in their childhood days, and now they have developed this kind of beaded appearance in their coronary course. So they just want help that whether this is the consequence of the Kawasaki disease in adult age. So I just want to hear from you about this.
Sure. It is quite rare that we do angiography for coronary disease. As you know, in children and they are very young, you really don't want to go and do selective, because that's the best thing to do. Selective coronary angiograms and put the catheters in them, especially when they were inflamed or they have disease. You don't want to add to anything. So we usually do not and just suffice or get contented with our echo follow-up. And extended parasternal long axis view can show the LAD actually in the septum, and even see if there are further dilatation inside or aneurysm. So the answer to angiography is usually no, unless there is a specific cause to do so. A patient presenting with signs on the ECG of ischemia or STT segment changes, a patient who has actually, you could see by echo, the aneurysm having a formed thrombus, which is already fibrosed and so on. Or it is only for follow-up. A patient who we followed since birth, since was like a year old, and then this patient now is almost getting to adulthood, and I don't want to send him to the adult world without knowing exactly how the coronaries are. And this is actually the most common indication for me to possibly do an angiogram, is really just to make sure I send them to the adult world with normal coronaries and no significant. And we know now that CT angiography is quite good. So again, that puts angiography by cath lab very low in need, and we really don't go for it. We had in the past 20 years, probably 2 cases who are Kawasaki and who required actually coronary intervention, whether just a balloon or a stent, and they were less than 15-year-old patients. As for the last comment about adults calling us for their aneurysms, we face the same. As for the adults, we face the same thing. I have been called a few times also by adult interventionists, show me aneurysms and ask me Kawasaki. When we, are you hearing me?
Yes, I am hearing you. Yeah.
You see, when we go with our adult colleagues, actually, when we looked up the topic, a lot of the aneurysms, even in adults, have no relation to coronary Kawasaki disease. They are usually related to their own ischemic disease, their own ectasia disease, and their own intervention. And it's not common, actually, that it is Kawasaki. The most common still remains their adulthood type disease.
Thank you, Dr. Jamila Lata. Is there any question from anybody else?
Madam, can I ask a question? Namil?
Yes.
Deliberation regarding the Kawasaki disease, I really enjoyed. My question, a small question, that is, how frequent you are finding the coronary involvement in Kawasaki disease, either complete form or incomplete form? Number one. Number two, regarding your question, when we use anticoagulation, actually, in case of dilated or in case of simple dilatation or irregularities, we use only the aspirin. But in case of giant aneurysm or some symptoms relating to coronary ischemia, in that case, we may sometimes go for anticoagulation. And nowadays, during this COVID era, we have learned to use this Rivarox 7. And I have used in one case this Rivarox 7 in case of giant aneurysm after coronary Kawasaki disease, and the baby had some symptoms and with some LV dysfunction. But the baby gradually improved with Rivarox 7. Thank you very much.
Thank you. I'll start with the last point as for the anticoagulation. Obviously, when it is 8 or more, then it is an aneurysm, whether it's just a total dilatation or it's an aneurysm. I think you are committed to anticoagulating them.
Thrombosis, which
yes.
is delineated by echo.
Yeah, and you were saying that you would anticoagulate them with the newer agents. Is that the last point?
Yeah, Rivarox 7.
Yes. You see, the newer agents like the oral anticoagulant, like Epixaban and the others, unfortunately, there are pilot studies and for those patients, and I do use them for patients who are older than 5 to 7 years of age. But again, it's quite in its beginning, and many of our pharmacies in the major hospital will actually refuse to dispense it for a child because they do not have it as an indication. And we have to convince them that we can use that. And pharmacies would not dispense it, especially if the child was less than 5. So I wouldn't recommend it. I would go for either warfarin or enoxaparin, which is well established. But definitely, if I have a 12-year-old where I want to anticoagulate, I would consider anticoagulation with oral anticoagulants plus aspirin, always plus aspirin, not alone, and so on. The first 2 points I didn't get well, Dr. Absalam. Dr. Noor Nahar, maybe you can, the voice was far a little bit.
Oh yes, I was muted. Yes, I think we have nicely discussed about Kawasaki. One of my student, you know him, Lieutenant Colonel Ashfaq, he is asking a question to you about your experience in post-COVID situation about the MISC or PIMS-TS. How many children you have treated and what is the frequency in your setup? Post-COVID MISC.
Yeah, thank you. I think we had post-COVID myocarditis in the last year in about 3 patients or 4 patients actually. 2 patients were cardiac transplant patients. One was a patient with corrected TGA with severe TR. And I think one with suspected Kawasaki. This is all the experience I have personally in the past 1 year where we had 1 year plus where we had Kawasaki. The very interesting thing I can share with you that in spite of cardiac transplant patients being on immune suppressive therapy, they actually do very well. And the 2 patients we had only came with other symptoms like gastroenteritis, coughing a little bit, but not much really symptoms of cardiac failure, although their troponin level was high, but this does not mean anything. Some may have high troponin and it's not necessarily a sign of carditis. All these patients did well. The patient with CCTGA really did very poor. She decompensated, knowing that she had moderate to severe left AV valve regurg, but she really decompensated. She had severe ARDS, COVID type, and her TR was almost like free. It's like free MR, poor function, and she had very bad VTAC, even torsade de pointe. And this patient, to save her life, we had to go on ECMO directly, and that was the only way to save her life. And fortunate enough, after 2 interventions, which are very experimental, one was we went ahead and did a septostomy on her on ECMO just to relieve the LA pressure and get the lungs to function better, and adding all the treatment for COVID plus the protocol of pulse steroids, she really did much better. And eventually we got her to valve surgery, and I hope she can make it. She's actually one of the last patients. She's still in the ICU, and I hope she'll make it. The other 2, the cardiac transplant did quite well, and the COVID one also did well, and we treated them the same. There's a question from Dr. Abdulaziz Maqsood regarding rheumatic heart fever. It is very difficult to diagnose at early stage as most features take time to develop. So can we include it as a disease to undergo screening in endemic areas in a certain age period? I think this question is a very good, important question. And maybe the screening would be not directed towards rheumatic fever, but directed towards screening for evidence of strep throat, either infection or colonization. That would be a good screening test. And if you find a population with high incidence of positive throat swab tests for gas infection, then those patients may be subjected to a more specific screening program by ECG and echo to see who from them can be a rheumatic heart disease patient that needs prophylaxis. Question 2 regarding Kawasaki disease, as atypical becoming a common picture, is the treatment same as atypical one? Yes, it's the same. The only difference is that we have a high suspicion and we started quite early. We don't wait for the atypical to become typical. And if the atypical has more issues in terms of being refractory, which is also can be seen, then we go into different modalities of treatment. Kawasaki disease may confuse with viral flu, yes, as an atypical one. So without confirming the case, is there any risk of Ray's syndrome starting the aspirin? I think Ray's syndrome took a very big propaganda that is not worth it and is not needed. When you think your patient has Kawasaki, give IVIG, give aspirin. The incidence and the risk of Ray's syndrome is almost negligible, if not zero. I don't consider Ray's syndrome when I need to use aspirin for those patients. I only consider Ray's syndrome when there is already a preceding liver disease or a hepatitis picture. Then it is different. Mr. Abjabar, thank you so for that presentation. How long we continue antiplatelet and anticoagulation duration? In some children have dilated coronary as part of drugs.
Water filter, the viral filter.
I think, Dr. Abdul Jabbar, your question, you would continue the aspirin as long as it is dilated more than 3 millimeter. You continue the aspirin and the Plavix as long as they are between 5 to 8. You will continue the anticoagulation as long as they are 8 or above. So there is no time limit. The limiting thing is that you stop when they are back to normal. That's when you stop aspirin. But beyond that, it's almost for life until they normalize. A lot of patients may normalize, maybe I would say 5% or 4% of your 5% probably of your patients with coronary involvement will actually not resolve and they will need treatment. I have patients who are on aspirin and anticoagulation today reaching 5-6 years period of treatment, and they're going to continue on that. You will only need to see one case of a clotted aneurysm and you will never want to see it again. We had a 12-year-old with a big aneurysm, and actually he was a missed Kawasaki, never diagnosed. He came to us with cardiogenic shock and died within 12 hours. On a cardiac biopsy, the myocardium infarction was so bad that the pathologist reported it as chocolate necrosis of the myocardium. So you really have to continue for long.
I think we can go to next session, Dr. Jamil. It's too long now, more than 1 hour. So
I think
you have one more, I think.
Continue
or,
in the next session, inshallah.
Okay. So
I appreciate your audience, your invitation, and I'm willing to be always with you and other topics. If you I want to give whatever I have and also learn from you.
yeah, all were very much interested. So many people were asking questions, and they have learned many things from your experience, and we also learned a lot from you. So with this, I would like to thank everyone for participating in today's online lecture session. And Dr. Jamil Alata, thanks a lot for giving your time. And We will again request you to take the rest of your lecture in another day, especially on cardiomyopathy.
Inshallah.
So thank you very much, and thank you Beximco for being the partner of this class, and thank you all my dear students and colleagues. Assalamu alaikum. Ma'as-salama.
مع السلامة في أمان الله.
Assalamu alaikum, Dr. Jamila Atta.
في أمان الله دكتور حنان. Nice to
Yes,
see you all
thank
and
you.
nice to talk to you.
Yeah,
কেউ
thank
কথা
you.
বলতে চাও জামিলা লাতা স্যারের সাথে?
Yeah.
If anybody
Yes,
want to
Assalamualaikum.
talk,
Ji,
he
madam,
is still
Assalamualaikum.
here. You can talk.
We are yet cherishing your,
كيف حالك?
yeah.
Very nice to see you.
Thank you, sir. You have been, you came to our CMS with and several times. So you are in our heart and throughout our life.
Allah, you are too. I wish I can be there with you soon. Inshallah.
Yes, sir.
May Allah
Inshallah,
take
sir,
care.
whenever, yes, sir, whenever we heard about your name, we memorize you with respect.
Jazakallah khair. Jazakallah khair.
Thank
And
you,
whenever
sir.
I see you and hear you, I memorize you with a lot of love and respect.
Thank
You
you,
all.
sir. Assalamualaikum.
You all. Jazakumullah khair. Thank you. Assalamu alaikum.
So I think we can leave now, Dr. Jamil. If you want to say anything
So much.
to everybody, you can tell them if you want to say anything. Oh, he left. আচ্ছা সালাম ভাই তাহলে শেষ করে দেই সবাই অনেক লেট হয়ে গেছে আচ্ছা ভালো থাকেন সবাই আর কালকে দেখা হবে সবাইকে কালকের অনুষ্ঠানে জয়েন করার জন্য আমন্ত্রণ জানাই কালকে আমাদের চাইল্ড হার্ট ট্রাস্টের প্রতিষ্ঠা বার্ষিকী রাতে 9টার সময় আমাদের একটা ওয়েবিনার আছে ওখানে সায়েন্টিফিক পেপার থাকবে ডিসিএম এবং একমোর উপরে সবাই জয়েন করবেন ইনশাআল্লাহ ভালো জিনিস হয়তো বলার আমরা চেষ্টা করব এবং সকলেই লাভবান হবেন ইনশাআল্লাহ আসসালামু আলাইকুম
Thank you, madam. Assalamualaikum, madam. Beximco. Beximco কে আছেন? হ্যালো Beximco ডক্টর নয়ন আছেন?
I just tell you that is Thursday morning in Bangladesh, that is Wednesday evening at your time.
বন্ধ করো
আচ্ছা